Alright, so today we're talking about sertraline, which I believe is the most commonly prescribed psychiatric medication in the world. So the structure of this presentation will be about the therapeutics of the medication, so kind of how does it work, what's its kind of class of medication, what is it used for. Then we're going to talk about the safety profile and side effects. We're going to talk about special populations, and then finally we're going to talk about tips and tricks in the dosing and the use of the medication. Of course, remember, none of this is medical advice. This is just patient information. Around what matters for you. So sertraline is classified as a serotonin reuptake inhibitor, technically a selective serotonin reuptake inhibitor. It does bind to other receptors, so there's some weak binding to dopamine reuptake transporters as well. And the mechanism is kind of speculated. So the way that it's used is that in large clinical trials, if you test the effect of sertraline against a placebo in a randomized control trial, people who have, not just depressive disorders, many disorders, I'll talk about them in a second, but the people who have the illnesses that it's targeted for will do better than those who just take a placebo tablet, and we're not 100% sure exactly what the mechanism is. When we test it in a lab, we can see what receptors it binds to, and from that we can kind of deduce what possible mechanism it has in the brain. So the thinking is that higher levels of serotonergic activity in the brain have help with some forms of depression and anxiety, and that is postulated to be the kind of mechanism of action that is kind of being debated as we speak. There are papers that have kind of shown that it doesn't have that much serotonergic activity based on some kind of different experimental techniques in humans, that what happens in the lab isn't necessarily what happens in the body. So essentially it's not completely understood, and that's the case with a lot of medications. So the evidence shows that we, at a clinical level, see that it can improve someone and how they feel, but at a biochemical, at a chemistry level, we're not exactly sure the mechanism in which that's occurring. So what is it usually used for? So SSRIs are usually called antidepressants, but they also have other effects. So major depressive disorder and atypical depression, sertraline is commonly used for. It's also used in anxiety disorders, so like generalized anxiety disorder, obsessive compulsive disorder, panic disorder. And it's also used in PTSD and some kind of phobias like social phobia or social anxiety disorder as well. Typically after starting, there's a delayed effect, so it's uncommon for people to get improvements straight away with sertraline. So 2 to 4 weeks before you start getting some improvements, and if there's nothing after 6 weeks, then really need to think about a dose adjustment at that point. And depending on the clinical situation, maybe your psychiatrist or GP will consider a dose adjustment at an earlier point in time. It's quite personal and specific to the patient in front of you. I guess it's helpful to think about it like an antidepressant effect and a pro-energetic effect, because I'm talking more about the antidepressant effect where there's a delayed effect. After 2 to 4 weeks, you should start seeing something, but in the first 2 weeks, you don't always see much. But often after a week of taking it, people do disclose a kind of sense of increased energy. So that is interesting, like that actually the energy comes before the mood improvement, but definitely worth looking out for. And so in that perspective, I guess it's important to take it in the morning, because for the majority of people, it will be energizing. Some people do find it sedating. We all have different kind of receptor profiles, and some people just have a different response to it and find it sedating. So in those people, they can take it at night. But I would say from 80 to 90% of the people that I meet on it are taking it in the morning, and I would always start it in the morning. If it's working, the goal is kind of the remission of symptoms. So it's about kind of reducing symptoms to a point where they're not clinically bothering you. And if it's a single episode of depression, people don't need to be on this medication forever. But some people do take it indefinitely, or very long term, especially if there's like recurrent episodes of depression or in some kind of moderate to severe anxiety disorders. So it's a medication that can be used for 1 year at a time, or it can be used longer term. If it isn't working, the typical thinking is you can consider doing a dose increase, after discussion with your psychiatrist or GP, you can think about augmenting agents, so using other medications that use with it, that can be used with it to amplify its effects. You can think about psychotherapy, and it's also really important to think about being evaluated for a different diagnosis because maybe the diagnosis is wrong. So in terms of the side effects, look, most of the side effects are thought of in terms of serotonergic actions. So, so having too higher levels of serotonin absolutely can manifest as a series of different side effects, and most of them can go away with time, but some of them might mean you have to think about dose reduction or changing medications. You've got to work that out with your doctor. But here are some of the notable side effects. So number one, sexual dysfunction. So in men, that can mean delayed ejaculation, so affecting your ability to orgasm, basically. And in both men and women, it can affect libido levels and cause an inability to orgasm. So that can be quite distressing, especially in young men and just young men and women. Sex is a really important part of life, and that can be very distressing. The second group of side effects is around the gastrointestinal side effects. So that's things just like nausea and diarrhea. For some reason, there's a lot of serotonin receptors in the kind of gastrointestinal system, and for some reason some people just get a really sensitive response to serotonergic medications, and just because you have side effects to one SSRI doesn't necessarily mean you'll have side effects to another, which is really interesting. But for some people, the sertraline just causes some serious kind of diarrhea, and they don't find it tolerable. And the third kind of group of common side effects is around activation. So as I was saying before, most people find it gives energy, and that can be actually quite distressing in some people, especially if someone's getting really negative thoughts and they didn't have the motivation or energy to act on those thoughts. Then they get increased energy before an improvement in the thoughts and mood, and so that can be quite a distressing situation. Some of the rare side effects, so very rare, but need to be aware of. So in some people, it can cause a drop in their sodium levels, called syndrome of inappropriate antidiuretic hormone, and that's the older the person is, the higher the risk for that. So that's something we measure in older people, and that can manifest as a delirium and confusion and someone being acutely unwell. It can be associated with seizures, and it can actually, in people who have a bipolar disorder, trigger a manic episode, especially if the dose increases too quick, and that activation syndrome is too much and the energy gets too much, and they can actually flip a depressive episode into a bipolar manic episode. And so monitoring for mania is a very important part of starting on an antidepressant, especially if it's the first time. And so just a comment around kind of suicide and starting on an SSRI. So the increase in energy it can be distressing if someone's having suicidal thoughts, right? Because if you're very depressed, low energy, and not feeling like life is worth living, you're less likely that, well, some argue you're less likely to act on those thoughts because you don't have the energy to kind of go through with it. And so in a paradoxical sense, it's almost protective that you don't have that energy. And the clinical pattern of an SSRI response like sertraline is that first you get a boost in energy, and then you get the improvements in mood. And so the boost in energy is in week 1 and 2, and then the improvements in mood is kind of week 3, 4, 5, 6 onwards. So the thinking is that could increase the risk of suicidality, because if you're having negative thoughts and then you get a boost in energy, you might act on those, suicidal thoughts. Look, that's the theoretical risk, and it's on the black box. It's on the warning labels on the medications. Short-term studies that monitored patients, notably the patients who were all over the age of 24, so I'm not sure about the under 24 age, did not show increases in the risk of suicide in that population. So I think if you're able to safety plan, if you're able to work with your healthcare providers, you've got a good support network around you, and the access to means is monitored and restricted. That's just all things to consider. But at the end of the day, it's a shared decision between you and your healthcare provider. And another 2 things to mention. So one is that in terms of psychiatric medications and weight gain, it's kind of in the low category. It's not strongly associated with weight gain, and same with sedation. So it's not a particularly sedating medication, as I alluded to before. So it's usually taken in the morning. And so what to do if you're getting side effects? Well, talk to your healthcare provider, but the typical advice, if they're not serious, is to watch and wait, and recognize that receptors in your mind and in your body are adjusting to the medication, that adjustment can be therapeutic, and that it will pass. So for all non-serious side effects, watching and waiting is the main advice. If it's intolerable, you can do a dose. Again, talking to your professional, you can consider a dose reduction, and some people will go as little as 12.5 milligrams because they're so sensitive. I'm sure people even do 6.25 milligrams. So if you need lower doses, that's absolutely fine. You just have to do what works for you, and then just be nice. Go, start low, go slow, kind of thing. If the side effects are intolerable. Okay, now in terms of dosages. All right, so I guess the range is kind of 50 to 200 milligrams a day, taken in the morning all at once usually. And typically, I guess depression and OCD tend to have higher doses, and anxiety, PTSD usually have lower doses. People can find a response after 25 milligrams, 50 milligrams, but some people need to go up. Especially OCD tends to need higher levels, higher dosages of SSRIs for treatment, and can go up to 200 a day. The typical pattern would be to start at a low dose, watch for 2 weeks, and then think about adjusting the dose. So that could be 25 milligrams, even 12.5 milligrams. Some people might start at 50 milligrams, especially if it's a bigger person who might have, especially if they've tried it before or something like that. I guess you just have to be aware that the higher the dose you start at, the more risk of side effects, because a lot of the side effects I mentioned are dose dependent. So dosing tips. Okay, well, tip number 1 is that the tablets are scored. So if you can actually save half price if you get a higher dose and then crack them in half. And if you ask your doctor, I'm sure they'll be happy to do that. So if you're at 50 milligrams a day, get the tablet for 100 milligrams, crack it in half, and then just take half a tablet a day, and then your supply lasts twice as long and you get 50% off. So there's your bonus tip. The next tip is if you're needing over 200 milligrams a day, so you're getting a partial response, but you think you still need more, which can happen in OCD, then that needs an expert kind of monitoring. And there are case reports of people on 400 milligrams a day and they're taking it safely with good effect. So there are situations where it goes beyond the guidelines, and that guidelines are there to guide, but they can't capture every person's unique circumstance. But you just need kind of expert monitoring. So I would suggest definitely having a psychiatrist involved if your dosages are going above 200 a day. I guess an important consideration is if someone is particularly anxious. So if you find that you have very high levels of anxiety, or after starting it, you become really kind of activated and distressed and more anxious after starting it. So you really got to start on a lower dose, okay, because it's dose dependent, and probably should be reviewed for possibility of bipolar disorder. That at least needs to be considered and excluded, because if you're having this kind of agitated, anxious, insomnic response to SSRIs, that could indicate the possibility, I'm not diagnosing anything, could indicate the possibility of a bipolar disorder that has not yet been diagnosed. All right, how to stop sertraline. So if you've been on it and you wish to cease it, it kind of depends how long you've been on it for. And SSRI discontinuation syndrome is a really horrible thing to go through. And that's what happens when you stop SSRIs too quickly. I guess there's 2 arguments. One argument is that actually it's not lethal, and so just pushing through with it can save you a lot of time, and then you can try the next medication sooner or get to know medications quicker. And then the other argument is that the symptoms are disabling and painful, and so actually you should down titrate very slowly. It depends, right? So some people who need to switch rapidly, I would say the quickest you can come off of it is as what Stahl's Prescriber guide suggests, which is half the dose for 3 days, half the dose again for 3 days, then stop. That's over the course of a week. I've never done it that quick. I go slow with these kind of things. So I suggest coming off of, if it's an option, like 3 to 6 months, you come off of SSRIs, and it kind of depends what the person wants. So if the person's like, yep, look, I get it, I'm going to have some withdrawals, but I want to move on, then you can kind of work with that. And there are things you can do to help reduce the impact of the withdrawal effects. And so that I'll leave that between you and your prescriber. All right, so special populations. Number one, people with kidney issues. So if there's renal impairment, frequently sertraline does not need any dose reduction. And if you're on hemodialysis, the sertraline is not removed by that process, so you don't need to adjust the dose or dose it before or after. It stays in your blood. Number two, liver impairment. So if you've got liver issues, then typically the dose does need to be adjusted. So you just need to talk to your doctor about how to do that. Some people with liver issues need the dose reduced by half and need to even take it less frequently than daily. So I haven't seen that before in my clinical experience, but that's what the kind of guidelines suggest. In terms of people with heart issues, so there are studies that looked at sertraline after heart attacks and people who have angina, and it was shown to be safe in those populations. As with all psychiatric medications, it just needs to be used cautiously if someone has QTc prolongation, which is something your GP can monitor for. So you just get the leads on the chest called the ECG, and it monitors the kind of heart intervals, how the timing it takes for different parts of the heart to contract. And one of those intervals is called the QTc, and some psychiatric medications can prolong that. And some people genetically or from previous heart attacks or many different reasons might have a baseline prolonged QTc, so that just needs to be monitored for. And in the elderly population next, so there's an increased risk of that SIADH, the syndrome of inappropriate antidiuretic hormone that I talked about before, so the low sodium effects. So that needs to be monitored for with blood tests, and really the rule is start low, go slow. Often people who are elderly respond to much lower doses than kind of young adults. So that's just kind of one of the principles of prescribing, and a lot of care has to be given to the other medications that the person is on because of the risk of what's called polypharmacy and drug interactions. So if someone's already on 4 different medications for, their heart and their kidneys and their liver or whatever, that increases the risks of drug interactions. And actually having more than 4 medications is associated with a bunch of increases in risks around falls and cognitive issues and hospitalization. So really, you've just got to be, the prescriber has to be really careful when someone has multiple medications and is an older person. And that principle of starting low, go slow also applies to the next population of children. So sertraline is one of the more common antidepressants used in children. And again, lower doses and slow to increase the dose range is the way to go. And in special populations like children, it just really needs a clear discussion around the risks and benefits of using the medications and the risks and benefits of not using the medications, and then a shared decision with the parent and guardian around the decision-making process. The next population around pregnancy. So pregnancy is difficult because it's not ethical to study in controlled studies, but there is kind of, sertraline's been around a long time, and so there's kind of a lot of observational data. I think pregnancy is something you really need to discuss with your doctor, and if you're in Australia, you can use different services like Mother's Safe, which can provide advice. Ultimately, there is an increased risk of taking maybe not any medication, but there is an increased risks associated with taking sertraline through pregnancy, but you've got to weigh up those risks with the risks of not taking it in pregnancy. And, if it means that you'll be unable to eat because of severe anxiety and then you'll be malnourished, then that's a very bad outcome and it might justify the use of using sertraline. So you've just got to have a shared decision making with your prescriber, and they can talk to you about the different risks. I would just make the point that the absolute risk is still quite small if the dose range is low, and but you've just got to weigh it up with your situation. And breastfeeding population, so same thing again. Look, most drugs do find some levels in breast milk, and that's the same with sertraline. So there is some amount in breast milk, but you've got to weigh up the pros and cons, and there's ways to reduce it. So timing the maybe expressing milk before taking the morning dose, that sort of thing. So the postpartum period is a very high risk period. So if someone's got a history of postpartum depression or is at risk of postpartum depression, sertraline can be life-saving, right? It can be really important. And so it's really about, again, that risk-benefit discussion with your healthcare professional, getting a second opinion if necessary, and then monitoring the baby and how the bub is going. All right, guys, I hope that was a helpful and informative video about Zoloft. Sertraline, it is a very commonly used medication. It has a safe side effect profile, and just with, as is the case with all medications, it's about a informed consent, so a shared decision-making process, understanding the risks associated with it, because there are risks associated with taking medications and risks associated with not taking the medications, and you have to weigh up the balance. It's often the case that there's no perfect answer, and I just hope that things are going all right, and I wish you all the best moving forward. I'm going to leave the video there, and I'll see you guys all in the next video. All right, bye for now.